I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU, Radio Hofstra University, to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing personal health records, which are increasingly popular ways to keep track of medical information. I'm happy that gives me the chance to have back on the show my friend and colleague, Dr. Michael Oppenheim. He is the Chief Medical Information Officer for Northwell Health and an Assistant Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Mike, welcome back to Well Said.
Thank you, Ira. I'm excited to be here.
So I didn't mention in the intro that you're also an infectious diseases doctor, which means you've probably been pretty busy lately. How have you been holding up?
I am well, thank you for asking. Happy to see the world in a significantly better place than the last time I was on the show, which was just after the first wave of the pandemic came through New York. So I'm happy we're in a better place and we have vaccine and vaccinations to keep things open and let our world run a little more normally.
Yeah. Well, we're all looking forward to a more normal world for sure. We're going to be talking about personal health records, and I mentioned that it's a way for people to keep track of information about their health. Could you expand on that a little bit? What kind of information would you expect to find in what we call a personal health record?
So personal health records are aggregators, really, for folks to collect their personal information, health information, from any number of sources. Probably the largest source of it would be from electronic records in their physician or other clinical provider offices. And many of the personal health records are able to electronically connect to systems that are used by those clinicians in their office to document their encounter with you. And so that's going to be a big chunk of the information that goes into the personal health record. Now, folks can also supplement with information that comes from other sources, whether it be, devices that they wear, measurements they've taken themselves that they want to add, or maybe information that comes from offices that are not connected to their personal health record. But the idea is to give a person a place to aggregate all of the information that's available about them. So from an office, for example, you would be able to get diagnostic information. So someone sends a laboratory test on you or sends you for a X-ray or some other radiology study, and those information comes back into the provider's record, and then from there flows into your personal health record. And in the early days of personal health records, we really were seeing primarily that kind of information, like lab tests or problem lists. Typically, when you see a clinician, they'll document what medical issues you might have. So, you have high blood pressure, you have elevated cholesterol, you're pregnant. Those kind of information would flow in also. The technology's matured, and frankly, the medical profession has matured that to the point where we're now not only just releasing these sort of specific, what we call discrete pieces of information, but actually full provider notes. Everything the provider wrote when he or she saw you in the office would flow into the record. So you can see not only the specific objective data, but what was the provider thinking? What did they think the problem was? What are they ruling out? Anything and everything that they document about you could also flow into that personal health record.
That prompts two questions then. So what exactly is the difference between the record that the doctor or the hospital maintains and a personal health record? That's question number one. And then question number two is, I know that many of our listeners are probably familiar with so-called portals, which are ways for people to gain access to the records that their doctors are keeping. Can you straighten out those three things for us? The personal health record, the electronic record that the doctor keeps, and a portal?
So let me start with the electronic health record or electronic medical record, terms used relatively interchangeably. That refers to software package that's typically used in a provider office or in a hospital, depending on wherever care is rendered, and all of the care works through that record. So prescriptions are ordered through that system, notes are entered through that system, results come back from laboratories and radiology services through that system, and that has a legal status of a record that the office is required to keep. And typically only people working in that office are able to put data in. Many of them allow patients to submit data through, let's say, a pre-visit form. You might fill out some historical data. But again, that usually is reviewed and verified by a provider before it can go in the record, because that is the provider's record, and it's subject to all sorts of legal, regulatory, billing rules and requirements and oversight. So it has some very, very stringent rules and guardrails around it. The next step in the evolution was the patient portal. So a portal and a personal health record do have a lot of overlap, but a portal is software that's used to help you interact with the provider's office and engage with a provider's office or some sort of healthcare agency's office. So a component of the portal might be a personal health record where your clinical information lives, but it is also a place where you might send messages to your provider. You might put refill requests in to the system for there. You might even be able to schedule follow-up visits directly on the portal, depending on the functionality. But it's really a portal, as the name implies, for you to get access into one or more providers' office. Some portals could be shared by many, many different providers. So some of the popular ones, the MyChart from Epic or Follow My Health, which is used by Allscripts and some other electronic health record vendors. But it connects you to one or more offices, really for both business interactions with the office as well as a personal health record. A personal health record, though, can be freestanding, and it could have nothing to do with that provider's office. It may not be tethered to the EMR. It may not be connected to the scheduling system and do some of the other things that we talked about, but it is specifically designed to be agnostic so that any provider that you're getting care from should be able to connect and send data in, and we can talk a little about the technology that enables that. But the personal health record is really much more the patient's own record for them to control, manage, to enter whatever they feel is appropriate, as opposed to a portal, which is sort of a link in to a provider or multiple providers' systems, but may have some of their clinical information, so that piece of it could be a personal health record subset.
So let me pick up on what you just said in explaining that about the personal health record is really under the control of the individual whose information is in there, as opposed to under the control of a healthcare provider. Is that correct?
Yes.
If that's the case, who has access to the personal health record, and what kind of safeguards are generally put in place to protect the privacy of that information?
So a patient health record is generally something that a patient, him or herself, would create. Typically, it's online. It may be an app you download, or again, in many cases, it's both. But the patient's in full control, and the patient then designates and says, please get information from this healthcare organization or that healthcare organization, and then again, they can supplement their own. So it's really fully in the patient's control. The patient creates it. And again, sometimes you may have someone other than the patient in the case of, for example, a parent on behalf of a minor child, or there are delegation opportunities where an elderly patient may decide to delegate authority to to an adult child who's responsible for their care. But generally, it is fully in the patient's control to decide that they even want to have one, which one they want to have, and who else besides themselves could or should have access. The industry itself is regulated. Now, one of the sort of legal distinctions, which may not be very interesting, between a portal and a personal health record is there are laws that govern privacy for healthcare organizations, the so-called HIPAA laws that I think people probably heard of. There's a separate set of regulations that governs the systems and the vendors who make personal health records. And there are privacy protections in the law, and there are industry standards that are expected of these vendors and to which they have to adhere. So, for example, some simple ones. You may try to sign up to some, like your banking websites, for example, won't let you use a not strong password, right? That's an industry standard. It would be considered irresponsible for a banking institution to let you have a password that's easy to guess. Those same standards are applied to personal health record vendors. So again, if your personal health record vendor lets you pick password 12345 or password 1, that's not consistent with the industry standards that are expected of personal health records. And similarly on the back end, their data centers are expected to have certain levels of security and intrusion protection and other sorts of technology to prevent accidental access to your information. So really they're giving you a platform that you set up, you control, and you maintain, and it is expected that there are significant technical protections around that under the rules that govern a personal health record.
For people who may be shopping around for one of these things, are there like gold seals of approval that indicate that a particular personal health record meets all of those standards, or how does somebody pick which one to use?
There are a variety of security companies that validate the security and privacy. Again, it's across industries. There's nothing specific for personal health records. So when you look at the websites, they'll usually indicate at the bottom who their certifying agencies are. That usually there's something about privacy and security in a link, and you'll see the names of any of a number of national agencies that certify security and privacy of technology, again, across industries, not specific for healthcare.
Yeah, let me ask you another question around the privacy and security, and maybe this is kind of a goofy or naive question, but where does the data actually live? Is it like on your phone, on your laptop, in the cloud? Where is it?
It really depends on the technical architecture the vendor uses. The most current state-of-the-art architectures has the data stored either in the so-called cloud or in a vendor data center, which for all intents and purposes means like the cloud, meaning it's not you. And then when you're looking at it from a web browser or from an app on your phone, you are getting a window into that information that if the vendor is really trying to be cautious about your data, that data does not stay on your computer or on your smartphone after you've finished with the application. Now, that's not to say it can't, because the applications on your phone and on your computer can also be considered secure. So some vendors may leave that data there and say, just be careful. They'll warn you to log out and do other things. So it's perfectly valid and appropriate for them to say that you're going to secure this application either on your computer or phone with a password, and so your data can stay there for you. But the typical architecture these days is that what you see on your phone is really a reflection of what's stored in a secure data center and doesn't persist on what we call an edge device, like your computer or your phone, when you're not using it because of the possibility of someone else getting access to it.
And that gets back to what you were saying before, that these data centers have to meet certain security conditions and like to be certified by these independent bodies.
Correct, because as we all know, you can lose your phone. Amazon can't lose its data center.
Okay, fair enough. Earlier this year, some new regulations went into effect that essentially mandate that healthcare organizations and physicians make electronic health data available to individuals to put in a personal health record. Do I have that right?
Yes, you're referring to the 21st Century Cures Act, which, among other things, has provisions for what they term something called information blocking. We don't like that name because it frames it in the negative. We like to think of it as information transparency, and essentially mandates that providers release information to patients in a very timely fashion, and it specifies a large breadth of information that's required to be shared, so it's no longer the organization's prerogative to decide, well, I'm going to share certain labs, but others might be, too sensitive for a patient, and I'm not going to share those. Those decisions are now out of providers' hands and have been made by the government as to what should be shared, which is basically everything. But most important, and perhaps least interesting to people other than folks like myself who like the technology side, it specifies a series of standards by which this information needs to be represented and transferred between systems. Because one of the biggest barriers to broad sharing, I mentioned earlier that in the ideal world, a personal health record could connect to a myriad of different electronic records from a myriad of different providers, but in reality, there are some significant technical hurdles around that, the largest of which is that lots of systems represent and store the same type of information differently. And one of the key features that your personal health record has to be able to do is to be an aggregator and sort of join that information together without duplicates. So, if two different providers wrote that you're allergic to penicillin, you don't want to see in your personal health record two listings of penicillin under your allergies. That would just be silly. And so that, and for many other reasons, having a single standard nomenclature and data representation format, as we call it, will enable this to work now for any system, right? If every electronic medical record has to share information using this set of technical standards and this vocabulary, and every personal health record has to receive it and process it in that format, it really enables us to get to that truly agnostic vision where a patient can say to every one of their providers, hey, send information into my personal health record. And so that's where this 21st Century Cures Act is really helping to leapfrog this agenda forward.
Is it working? I mean, are people flocking to personal health records and demanding the transfer of information from their doctors and hospitals into them?
I think it's hard to know at this point exactly what the uptake will be. I think people are hearing about it, and there are definitely some requests coming in. But whether at this point it's sort of a select subgroup of people who are either more technically savvy or more eager to get their hands on their information electronically because of some specific medical issue that they're trying to solve, it's hard to know yet at this point what the impact will be in the general population.
And do you think that's because people don't know about these things, or they just haven't found them all that useful at this point?
I think in the past, there have been a number of companies who've gotten in, large companies such as Microsoft and Google, who have gotten into the personal health record business and then kind of stepped out. But I think it's probably multifactorial. I think there was significant limitations in the amount of information that could be transferred into those records, and therefore the value proposition was not there. So that part is being addressed by the Cures Act, which will make a much broader record set, including, as I alluded to earlier, provider notes available to patients. But I also think there's some subsegment of the population, and maybe a larger one, especially those with multiple chronic illnesses, who are quite intimidated by the amount of information, the detail, and quite honestly, the technical complexity of the information. Right? And so one of the real tricky pieces that is not addressed in the regulation, and I don't know exactly how this is going to flow forward other than perhaps from public demand, but we have a requirement under these regulations to make the information available. Right? What's not yet there is any requirement to make it fully comprehensible.
Okay.
And I'm not implying that medical providers are trying to hide anything, but when you get a list of 20 labs, under their technical names, sodium, potassium, glucose, calcium, magnesium, phosphorus,
right.
Hemoglobin, mean corpuscular volume, these are overwhelming terms for folks. And so there's, I think, in my opinion, a little bit of a gap to overcome to drive personal health record adoption in making the information more comprehensible and processable by patients.
Yeah, it sounds like an interesting business opportunity for somebody to crack that nut.
Right. So the question is exactly where is that going to come from, right? So is that going to be a mandate from the government? So far, we haven't seen indications. Is that going to be a groundswell from patients demanding, hey, we're not going to take it anymore. You better tell us what all these things mean because we can't just sit here and Google 30 labs every day. Or is it going to come from some very creative entrepreneur who says, you know what, I'm going to build overlays onto these personal health records that are going to be translators and help you get more understanding of what's in that information. I don't know where this is going to come from, but I do think it's a barrier. I think for many, many people, the information with all the technical jargon and clinical terminology that fills a record can be daunting, especially to someone with multiple chronic illnesses.
Sure. So we've been talking mostly about information coming from doctors and healthcare providers, but a lot of people are now generating their own data, right? So I'm wearing an Apple Watch right now. That can check for abnormal heart rhythms. It can detect if I've fallen. It keeps track of my exercise and so on and so forth. And that's just one of a large and growing list of wearable kinds of devices that people are using to gain insight into their health. What do you see as the future of integrating that kind of information into a personal health record and helping people make sense of it?
I'm actually very passionate about this space. I think the emergence of sensor-type technologies, both for provider use and in our own hospitals and for patients that we provide medical-grade devices to for home monitoring, I think the potential is unlimited. But I think we have a big mountain to climb, because interpreting this data is going to require very sophisticated algorithms, probably require artificial intelligence and machine learning-based algorithms to really figure out what to make of this information. Because for one person, that heart rate of 120 that you experience because you're on the treadmill, is perfectly normal for you in the context of the activity you're doing. Right? A heart rate of 120 in someone who's reading a book or watching television or doing very minor activity, and their heart rate goes up very exaggeratedly for that amount of exercise, is pathologic. Right? And that's just a very simple example.
Mm-hmm.
And then we start expanding to all these other types of parameters, and you're talking about things like ambient sensors that are looking at your motion around the house and how much you're moving. And I've seen sensors that sit on your pipes and determine how many times you're washing your dishes and showering in a day for geriatric populations. Right? But how we understand this data and make intelligent correlations between it to actually come up with valuable insights is the next grand challenge, because there's no way that providers, or patients for that matter, can look through the myriad of details that are coming through and really, other than, you may have an event, right? So you have an atrial fibrillation or some other abnormal heart rhythm. Good, so that's pretty straightforward. But then again, even there, if someone known to have atrial fibrillation, and our goal for you is not to have you never have atrial fibrillation, but it's to minimize the amount of time that you are in atrial fibrillation, for example, right? The interpretation of the signal from your watch is going to be very different depending on the context of the patient. And that's where AI and machine learning and other things have to come in to help us really sift through the sand to find that pearl.
And do you think that we're headed in that direction?
Absolutely. This is something that lots of people are starting to think about, both large companies and small startups. We talk to them all the time. Seen actually one really interesting company that has done just this. They are meant for the post-discharge space, and what it basically does is it spends the first 36 hours after a patient goes home learning their patterns,
home
and then
from the
can
hospital.
very, very accurately after that detect when they deviate from their own baseline. Right, so each person's baseline is established, and then we see when they that's the kind of thing that we have to make this valuable and predictive.
We've been talking about the deep analysis of essentially a particular individual's data. What about the aggregation of data across individuals to gain insights into mechanisms of disease or the efficacy of different treatments? Where do you see that developing?
These large data sets that will accumulate in these device companies are very, very interesting fodder for research on, again, any number of things you alluded to, general wellness and being, undetected side effects of medications that we never knew happened, but suddenly we find out that these patients with devices who are on medication X, experience a certain side effect that they don't complain about, but we may need to know about. Who knows? I think it's wide open field. The big concern, though, with looking at this data and with artificial intelligence and a lot of these technologies in general, is the risk of bias, because you are likely to see certain segments of the population overrepresented in this device-wearing, home monitoring space. And you have to be very careful about making extrapolations from these large data sets when you have likely only sampled some part of the population, right? So You probably won't see as many elderly patients. You may not see, some socioeconomically disadvantaged populations because they may be less likely to be investing in these types of devices. So you have to be extremely cautious when you look at what we learn from these to understand who are the population that you are studying and to be careful not to extrapolate and assume that your conclusions are true in other populations. And that's one of the biggest mistakes that's made in any sort of artificial intelligence or machine learning type endeavor. Because if you're working with electronic data to begin with, you've probably selected a subset of the population and do not have a full representation of everybody.
I imagine there would also be significant concerns about privacy and control of information about individuals if you're then talking about somebody looking across thousands, maybe even millions of records to kind of generate these insights.
Almost all the companies in this space are using technologies called de-identification, right? So they disarticulate and take off anything that could uniquely identify the patient from the actual data set. So the people working with the data can't figure out who this person is, right? So I'm a 53-year-old Caucasian male who lives in the zip code I live in, and that's about as far as you're going to know about me from a personal identification perspective. So there are some who might oppose to say, look, even with my identifying information over, I don't want you using my information. There are other people who are going to be more comfortable saying, all right, if you take my name off, sure, do what you want with it. I think that becomes a personal choice. And the most important thing is, and I know this is a painful recommendation, but when you sign up for these applications, whether it's the Fitbit site or Samsung, Google Fit, you name it, there is an end user license agreement, the so-called EULA, E-U-L-A. And you've got to look through it. And they will tell you, they have to tell you in the EULA what will happen to your data. And if they're saying we're going to use it for anything and you click agree without reading it, you've just agreed to that. So read the EULA, the end user license agreement that's going to come up at the beginning. Do scroll through it. Most of it you can skip, but you will see sections that will talk about data use. And you got to read those, and then you will know what they are and are not doing with your data.
Although, let's be real, for most of those, it's not really a choice, right? Like if you want to use that product, you got to check the box and say agree or I've read this, even though none of us really read it.
Well, correct. You don't have the opportunity to say no thanks and send back a legally red line
right.
Set of changes, but you have an opportunity to pivot to a different device and say, you know what, maybe brand X is not the right one for me because I don't like their EULA, but the market is so full of products now that maybe you'll find a product where the EULA is a little more to your liking.
Mike, this has been fascinating. Is there anything else you want to make sure our listeners hear from you about personal health records or the other subjects we've been talking about this afternoon?
I think the most important thing is, at least from my perspective as a provider, the value of the personal health record is to enable you to partner with your provider better. Maybe you're supplementing information that he or she would have access to with information that they wouldn't have access to. Maybe you're adding your own insights, or maybe it's just that you can do some preparation for your visit because you've already seen what your abnormal labs are, and now we can go in and discuss it. Whatever it is, the goal here is not to turn people into their own individual caregivers. Right? Providers are here to give care. We want the most educated consumers, most educated partners in the healthcare journey, and that's where the personal health record comes in. But no one's goal here is to say, I'm going to give you this information, now you should make all of your own medical decisions. Your provider is your partner, your physician, clinician, PA, whoever you're seeing, and this is a tool to help you and your provider work collectively towards decision-making around your care.
Well, I certainly agree with that, and I think that's a terrific way to end it. So thanks so much for coming back on the show.
Absolutely. Thanks for having me.
My guest has been Dr. Michael Oppenheim. He's the Chief Medical Information Officer at Northwell Health. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.